Welcome to Oncology Morning Commute, Understanding the Heterogeneity of Endometrial Cancer. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by educational grants from AstraZeneca Pharmaceuticals and Merck Sharp and Dohme. In this first podcast of our three-part series, Dr. Bradley Monk and Dr. Bhavana Puthuri discuss the heterogeneity of endometrial cancer and its four molecular classifications. How do these classifications help determine patient treatment plans? Information about the faculty and disclosures can be found at morningcommutepodcast.com/endometrial3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Monk is a professor in the Division of Gynecologic Oncology at the University of Arizona College of Medicine and the Creighton University School of Medicine in Phoenix. He is also USA Director and Principal Investigator of Community Research Development at the Honor Health Research Institute in Scottsdale, Arizona, as well as Vice President and member of the Board of Directors of the Gynecologic Oncology Group Foundation and co-director of GOG Partners. Dr. Puthuri is Professor of Obstetrics and Gynecology at the NYU School of Medicine, the Medical Director of CTO Perlmutter Cancer Center, and the Director of Gynecologic Oncology Clinical Trials at NYU Langone Health Perlmutter Cancer Center in New York City. I am your host, Candace Hoffman. Dr. Monk will begin our discussion.
Greetings and welcome. My name is Brad Monk. I'm a gynecologic oncologist here from Phoenix, Arizona. We have two medical schools here in Phoenix, the University of Arizona, which is not in Tucson, we're in Phoenix, and Creighton University, which is not in Omaha, we're here at Phoenix. And it's my pleasure to be here with my really good friend and one of the smartest people I know. Go ahead, Bhavna, introduce yourself.
Yeah, hi, I'm Bhavana Puthuri. I'm a GYN oncologist at NYU Langone Medical School, and I also serve as the Clinical Trials Office Medical Director and work very closely with Dr. Monk in the GOG, and am pleased to be speaking with you all about endometrial cancer today.
Yeah, that's a great segue. So we're going to talk about uterine corpus cancer. That's epithelial, that's carcinoma, endometrial carcinoma, as you outlined. So I think all of you know that last year there were about 66,000 new cases. It is now by far the most common gynecologic malignancy, and it will soon be the most lethal. Last year there was 12,940 deaths. Globally, it's more than 97,000 deaths. That's a terrible situation. Bhavna, why don't we go ahead and start with the surgical treatment? What's the appropriate surgical treatment for endometrial cancer?
Yeah, so most endometrial cancers present with vaginal bleeding, and most are your garden variety or endometrioid type, and they usually present at an early stage. When they come to see a gynecologic oncologist, usually we offer them surgery as the standard treatment. So that's removal of the uterus, the cervix, both tubes and ovaries, as well as a sentinel lymph node where we inject a dye into the cervix and see where it goes and remove the most likely affected lymph nodes. In some cases, when patients are either too sick to undergo surgery, we can offer them more conservative treatments such as radiation and, in select cases, hormonal therapies. And then in more advanced disease, we can offer them chemotherapy and other treatment options.
Yeah, that's great. And there's a fertility sparing option. It never made any sense to me is that a woman wants to get pregnant, so let's put an IUD in her, because obviously the purpose of an intrauterine device is contraception, but I get it has less side effects from systemic hormones. We're not going to get into all of that. But so endometrial cancer traditionally has been staged. The stage obviously is surgical. It's been updated based on the depth of myometrial invasion, cervical extension stage 2, and then nodal ultimately stage 3C. But histology has been also an important sort of way we look at them. So endometrioid tumors that under the microscope look endometrioid, serous, which under the microscope have sort of a tubal phenotype, and then obviously clear cell, mucinous, and even some other rare histologies. But ultimately, in 2013, hard to imagine 9 years ago, published in Nature, was the Cancer Genome Atlas Research Network. Tell us about the molecular classification beyond surgical stage, beyond histopathology, and now we can look at the tumor from a molecular standpoint.
Yeah, so as you alluded to, the TCGA was instrumental in identifying the 4 clinically significant molecular subgroups that had very differing clinical prognoses, and those include the ones with POLE mutations, the microsatellite instability high or MSI high, or DMMR, which is mismatch repair deficient, and then the copy number low, and the copy number high. And so, I think these are really important because they really categorize our endometrial cancers into these very specific buckets where they each behave differently. So, for instance, the POLE mutated endometrial cancers have a very good prognosis. And there are studies that are actually looking at, eliminating treatment, adjuvant treatment in these patients. The microsatellite instability high, or the deficient mismatch repair category are tumors that respond exquisitely to checkpoint inhibitors or immunotherapy, and have kind of an intermediate prognosis. And along with that are the copy number low, which usually are our typical endometrioid grade 1 to 2 tumors, and also have intermediate prognosis. And then finally, we have the worst actors, or the copy number high, and patients that have typically the serous tumors, and usually those tumors overexpress p53. So those are the p53 mutant tumors.
Yeah, I love that explanation. I love this idea that they're both prognostic and predictive, that the POLE ultra mutated tumors have a better prognosis where de-escalation is possible. And they're also exquisitely sensitive, not from the MSI perspective to checkpoint inhibitors, but because of the TMB, it's not uncommon to see a 90, 100, 150 mutations per kilobase in that setting. In the MSI ultra mutated, now there's 2 different ways that they can be microsatellite unstable or instability, DMMR, if you will. They can either be epigenetically silenced or mutated. So tell me about those 2 different opportunities.
Yeah. So I think what what we're trying to really talk about is the majority of the tumors that fit into that bucket are actually the ones that are that have epigenetic loss. And that's typically with loss of MLH1. And about 70% of the DMMR/MSI cohort are comprised of the epigenetic loss. And the other 30% are usually due to somatic mutations. So mutations in one of the mismatch repair genes, MLH1, MSH2, MSH6, or PMS2. And, there's been some, I think what's so interesting about this, categorization is there has been some early data that may suggest that the checkpoint inhibitors may be less effective in the ones that have epigenetic loss, but those were done in very small subsets. And most recently, the Garnett data looked at this very question, and it was presented at the recent IGCS meeting in New York this past past September, and there was actually no difference in efficacy noted based on whether it was due to an epigenetic loss versus a somatic mutation. And so I think there's more to come on that, but I think it's important to understand that, it can be due to either one of these mechanisms. But I think most important is that, all our endometrial cancers should now be tested for with mismatch repair IHC and or MSI. And, the NCC and, guidelines actually very clearly state this.
Yeah, that's great. And routinely, I would also do P53 using immunohistochemistry because that would help us understand if it's a copy number high. I would also do estrogen receptor and progesterone IHC, which isn't exclusively copy number low, but it sort of helps further divide that into that setting. So, one of the things that you've taught me, obviously, we talked about stage, we talked about histologic subtype, we talked about molecular classification, but it's ultimately the fifth, which is the most emerging, is the ethnic diversity and differences in endometrial cancer, something that you're very passionate about. Tell us about that.
Yeah, so that's great, Brad. But before I go on, I also want to add that something else that we have recently incorporated doing is in all our high-grade tumors, we're also testing for HER2. So we're doing HER2 IHC.
Bingo. I love that. Thank you for that. That's because trastuzumab is NCCN recommended.
Exactly.
I love it. Thank you for saying that.
Yeah. So so now that's incorporated, and also trastuzumab is NCCN recommended based on Dr. Amanda Nichols-Fader's phase 2 data, which showed benefit PFS and OS benefit. And there's GY026 that's actually looking more closely at a combination of trastuzumab and pertuzumab with chemotherapy in endometrial cancer. So, so for those reasons, and there's also really, there's some amazing clinical trials out there that are looking at small molecule inhibitors such as tucatinib, as well as the emerging HER2 ADCs, where our patients may benefit even if they have low expression. So, we've certainly added that.
And I was so excited to get to the diversity, but you can also study, and we're doing CDK4/6 and hormonally driven copy number low tumors. But tell us about this diversity issue. It is one of the sort of least understood, where the type of cancer that a woman gets might differ based on her ethnic background.
Yeah, no, this obviously, right. This is so important because we've noted increase in incidence and mortality in endometrial cancer. And there was a recent publication in the Green Journal that showed that the mortality of endometrial cancer is now approaching that of ovarian cancer and will likely soon surpass that. So I think, these are real issues, and we need, and one of the reasons that we're seeing this is that it's because of the higher incidence of higher risk histologic subtypes that we're seeing in the non-Hispanic Black population. And we know that Black women are 2 times more likely to die of uterine cancer. We know that the 5-year survival rates are 84% for white patients, 63% for Black women. And we know that, since 2015 to 2019, the deaths from uterine cancer have been increasing by 1% every year. So, and a lot of this is related to, the trends that we're seeing in terms of the increase in Black patients. And it's not just what we call the social determinants of health, which is really, the condition and the environment where people are born, live, learn, work, play, worship. But it's really, access to the economic, the education, the healthcare access, the neighborhood, the social and community. But these are some of the reasons, but there are also these biologic reasons, right? We're seeing a higher incidence of uterine serous cancers, and those tend to have a higher risk of CCNE aberrations, which we know have much worse prognoses. In addition, there is a higher proportion of carcinosarcomas among Black patients. So I think understanding that there are reasons that are biologic, but there are also these social determinants of health, which are leading to delays in diagnoses, less likely to receive standard of care, less likely to access clinical trials, are all adding to this problem. And in addition, the obesity epidemic, where we're seeing rising rates of obesity, which also affect our Black population, and is also contributing to this increase that we're seeing.
Yeah. So if I was to pick one word to describe endometrial cancer, it would be heterogeneous. Okay. They're not all treated the same up front with surgery. We talked about it. They don't all have the same histologic subtype, molecular characteristics, and ethnicity matters. And you know what that means? That means they should be treated differently. And I really appreciate your efforts. Both of us have the opportunity to participate in the GOG Foundation, and you lead a group, an initiative to ensure to our very best ability that the studies that we do, that we have a diversity plan, that we actually have a plan to enroll patients of ethnic diversity. And to have a plan not only to get it done, but also to help interpret that, because unfortunately, most of the trials that we do, not only in GOG Foundation, but throughout oncology, are predominantly Caucasian white. And so we really need to do a better job. I appreciate, that what you're doing. Now, next, I want to talk about sort of the established systemic therapy, the chemotherapy. We've been working on this for a very long time within the GOG, as you know, and other groups. But the first sort of opportunity that we had a survival advantage was a triplet versus a doublet, GOG 177. That showed that the triplet, platinum, taxane, doxorubicin, was better. And ultimately, we had to do a non-inferiority trial of this taxane, doxorubicin, platinum versus carboplatin paclitaxel called GOG 209. So I think that has evolved into the standard treatment now, given the caveats that you said, adding trastuzumab in the front line when appropriate. So why don't you tell us the role now of radiation as an adjuvant? Again, first line, you do a hysterectomy, as we've talked about it. You've categorized the tumor in the categories that we just said. You say, look, she has risk of systemic spread. I'm going to give her chemotherapy. But what's the role of radiation in newly diagnosed endometrial cancer?
Yeah. So, typically I utilize the GOG high intermediate risk criteria and the high risk criteria to determine whether I'm going to give vaginal brachytherapy. And usually if patients meet the GOG 99 criteria, which is based on the LVSI, the age, and the depth of invasion, so utilizing local factors, then I will refer them to my radiation oncologist, and they will typically get 3 fractions weekly of vaginal brachytherapy. And if they meet the high risk criteria where there's cervical stromal involvement or other, higher risk factors, then they may receive pelvic radiation. I typically tend to use chemotherapy for nodal disease. I am not a proponent of utilizing the combination of radiation and chemotherapy, as I don't think that the data really justifies it. But I'd love to hear what your thoughts are, Brad, in terms of the PORTEC data and how you utilize chemotherapy and radiation in the nodal, like the 3C1 and the 3C2 population.
It's remarkable how similar we are in our practice patterns. And so, PORTEC sort of had the wrong control arm. The control arm should have been, chemotherapy.
Exactly.
It wasn't. And so I just don't know how to interpret it. It doesn't mean that it wasn't a good study, but GOG 122 definitively showed, in my opinion, that chemotherapy was better, superior to actually whole abdominal radiation. And then we wrote a sort of an ancillary study with if you just had one positive node, 3C1 node, chemotherapy was still better because the risk of distant failures was significant. Now, if you want to layer in some vaginal brachytherapy, that's fine. I was struck from the frontline treatment this year at the International Gynecologic Cancer Society that there was a study done that added chemotherapy to radiation in the setting of a vaginal recurrence. And many of those patients did not have vaginal brachytherapy. And it sort of stands alone in the only tumor type that we treat where chemotherapy did not improve outcome. If you have a cervical cancer, basically you give chemotherapy. If you have a vulvar cancer, you give chemotherapy. Even if you have an anal cancer, you give chemotherapy with radiation. Do you have any idea why that study did not improve outcomes when chemotherapy is added to pelvic radiation in the setting of a cuff recurrence? Do you have any idea why that was negative?
Yeah, no, it was very interesting to see that, there was no difference. And I know you've thought a lot about it, Brad. What are your thoughts?
I have no idea. It should have worked. I love the pivot. I had no idea, and I'm a big proponent and concurrent chemotherapy with radiation, and I don't know why it didn't work. And that study, as you know, is known as 238 and was presented by Ann Klopp from MD Anderson. So that study will never be repeated, and it was probably one of the most practice-changing presentations that I've seen this year. So
yeah, I would agree. Even though it was negative, I think it was it really will right. It will all have us do the right thing when we are treating patients like that, and utilize radiation alone. So I 100% agree. But yeah.
One of the other heterogeneity things that I want to talk about, and then we'll close this out, is age. So we have an aging population, and many of these copy number high patients are, I hate to use the word elderly because, every year I get closer to that, whatever that threshold is, but they're older. They're older, and that matters. And not only does it matter because of their age, but they have concurrent medications. Any comments on the importance of age in these newly diagnosed patients?
Yeah, no, I think they are getting older. And I honestly am seeing patients who are much older, and you'll be like surprised. I just put a 90-year-old on one of my clinical trials with endometrial cancer. So I think it just goes to show you that, given that these patients are older, they do have many more medical comorbidities, and which makes treating them a little more challenging. And especially with many of the newer therapies that we have approved. Where things like lenvatinib, which is a TKI and causes hypertension, like we have to be that much more careful as we are prescribing these therapies to our patients.
And I get it, it's functional age, right? But still, my dad is almost 90 and he's in great shape, but he's still almost 90.
Yep.
So I mean, no one leaves this place alive. So this has been a great discussion on heterogeneity of endometrial cancer. Just to review, obviously, surgical stage is one of the most powerful prognostic factors and determines treatment. Traditionally, histologic subtype, I think still has value. But more importantly is the molecular signature, the 4 molecular categorizations that you described. Again, not only prognostic, in other words, how the patient's going to do, but predictive of treatments such as checkpoint inhibitors and hormonal therapy. And then emerging, obviously, is diversity. We need to study the treatments among the patients that are going to get it in sort of a real world evidence opportunity. And then now number 5, age. And that's perhaps the least well studied. And maybe that's your next opportunity, Bob, is to begin to study patients who are older. And we've done this a little bit in ovarian cancer. We've done it, I don't even think hardly at all in endometrial cancer. So maybe we can take that is an action item. So on behalf of Dr. Pathuri and myself, Brad Monk, it's been my pleasure to be with you. Thank you for your attention. I hope you learned at least a little bit. I know I learned from listening to Dr. Pathuri. Thank you, and so long for now.
And I always learn listening from you, Brad. It's been great.
All right. Talk to you soon. Thanks.
Bye-bye.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/endometrial3. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.